there and welcome everybody. Dr. Krista here, and today we're talking about neuroplasticity, specifically how to create treatment plans that stimulate neuroplasticity with your patients. At the American Posture Institute, we always keep it really results focused, so we're going to talk about how you guys can increase your results today. So I know I have a ton of you guys registered, which is awesome. I always commend all of you guys for joining us on the live webinars. You guys are the action takers, and I love it. So as you're logging on, just let us know who you are, what's your name, and where you're from, where you're listening in from today. And of course, if you're a CPE or a CPN in our group. So it looks like we got Nicholas from Melbourne. Hi, hope you're having a wonderful day down under. It's got to be nice over there, I'm assuming. And yeah, as you guys are logging in, again, just let us know who you are, where you're from, and if you're a CPE or a CPN. Also, if you want to take a minute and give us a shout out on social media, let your friends and your followers know that you're increasing your education about neuroplasticity so that you can serve them better in your practice by joining the American Posture Institute on a webinar today. So let your community know that you're dedicated to the advancement of your education and continuing ed on Facebook. All right, looks like lots of you guys are logging in. We got Nicholas, we got Kevin from Chicago, a CPE. Hey, Kevin. Nicholas, good morning. Sean from Metro Detroit coming in from Michigan. Hey, Sean, hope everything's going well. Again, guys, as you're logging in, just let us know where you're coming from. So we're going to get started today. Today we're talking about neuroplasticity. And as I was just mentioning, I know you guys, you guys are logging in still, but as I mentioned, we're going to keep this really results focused. So how we're going to go through the webinar is I'm going to give you guys a bunch of tips and tools about neuroplasticity. Then I'm actually going to go through a sample treatment plan, some sample exercises that you can utilize with brain-based postural correction. Then we'll go through a case presentation. And then after that, I'm sure you guys are going to have some questions. So we're going to open it up for a live Q&A at that point. So if you have any questions as we're going, feel free to type them in the side just to let you know I might skip over them, I might miss them. Dr. Mark might be able to respond right away, and if not, we're going to do a live Q&A at the end so you can ask your question at that point. But if you have any questions as we're going through the material, be sure to jot it down so you don't forget. All right, guys, as you're logging in, again, just remember to give us a shout out, say who you are, where you're from, and of course, give a shout out on social media, letting all of your friends and colleagues know that you're increasing your education today with the American Posture Institute on a webinar about neuroplasticity. The more education that you do and the more implementation from these webinars and this increased education helps you serve your patients at a higher level, and that's what it's all about at the end of the day. It's all about the patient, and we're going to talk about that today. So we got Sam coming in from Virginia. Hi, Sam. Hope you're having a great day. Thanks for joining us. So Sam, maybe you're on your lunch break right now. So we have, it's funny when we do these webinars, we have people from all over the country and all over the world. So everybody's coming in on different time zones. We got Jan. Let's see, Jan from sunny California. Hey, Jan. Thanks for joining us. We always appreciate you being here. All right, so let's get in and talk about neuroplasticity. So first of all, what is neuroplasticity? So neuroplasticity refers to the brain's ability to restructure itself after training or practice. It's the ability of the nervous system to respond to intrinsic or extrinsic stimuli by reorganizing its structure, function, and connections. So our brains are dynamic, and they can reorganize by forming new neural connections throughout our lives. Neuroplasticity allows the neurons in the brain to compensate for injuries and diseases and to adjust their activities in response to stimulations from the environment or changes in the environment. So what that means is that neuroplasticity is our brains are plastic, they're dynamic, meaning that we don't get to a certain age and quit our development in terms of brain function. Just the opposite. Every time you're stimulating your brain, you're creating new neural connections. You guys have probably heard the phrase that neurons that fire together wire together. So when neurons activate at the same time as a response to an event or response to rehabilitation or an environmental change, the neurons become associated with one another and the connections of the learned skill grow together. Now, this is good news and it's also bad news. So let me give you the bad news first, and then we'll talk about the good news. So the bad news is that there's what's called negative neuroplasticity. So there's positive neuroplasticity and there's negative neuroplasticity. So if neurons that fire together wire together, then if we're providing positive stimuli to the body, that's a really good thing. We're building a lot of positive neuroplasticity. However, if we have an injury or chronic pain patterns or chronic stress or chronic toxins from the environment, that's going to create what's called negative neuroplasticity patterns. So we want to, of course, focus our attention today of how we can increase positive neuroplasticity and decrease negative neuroplasticity that's going to hinder our ability to get results with our patients. So if we talk about factors of neuroplasticity, of positive neuroplasticity, that's going to be, for example, physical activity. That's going to be an example of positive neuroplasticity, intellectual pursuits, and social interaction. So those three things in particular are going to stimulate that positive neuroplasticity. So think about intellectual pursuits. If you guys think about, this is an extreme example, but it's going to make the good point. So if you guys think about patients later in life, maybe they're suffering from dementia, for example, and the ones that stay active and that are doing intellectual pursuits such as crossword puzzles and games and activities to utilize their brains, they stay more fit and they stay more aware. Whereas when patients stop utilizing their brain for intellectual pursuits and they are sitting and they're more sedentary, that's going to have a decrease. That's going to have that negative neuroplasticity, and they're going to lose that brain function, that cognitive decline. So those three things, physical activity, intellectual pursuits, and of course, social interaction. So meeting that need of social interaction is really important for positive neuroplasticity. And what the research is saying about positive neuroplasticity is that refers to the physiological activity or ability of the brain to form and strengthen dendritic connections, produce beneficial morphological changes, and increase cognitive reserve within the brain. Now, if we talk about factors of negative neuroplasticity, then we're talking about poor sleep, we're talking about substance abuse, lack of nourishment, stress, anxiety. So even if you're working with patients in your office and you have them on a great treatment plan, recognize that their ability to make neuroplastic changes to the posture system can be hindered or stunted due to these other factors in their life that's creating negative neuroplasticity, or at least hindering their ability to advance forward with positive neuroplasticity. So it's important to have a conversation with your patients, especially about sleep and stress. So whenever we start a treatment plan with a new patient in terms of brain-based postural correction, we're always talking to the patient about how much are they sleeping, because we're driving them to the point of neural fatigue with their treatment plans. Every time that they're doing brain-based rehabilitation, they're actually going to the point of neural fatigue. We want to drive that system, because when you drive the system, that's when you can make those neuroplastic changes. But if the patient has a very low amount of sleep and a high level of fatigue, they're going to go to neural fatigue much faster, and they're not going to be able to make those neuroplastic changes. They're going to have decreased progression in terms of their results. And also stress. So if they're highly stressed, they're going to be pumping out cortisol, and they're going to be increased fatigue, and it's just going to hinder their ability to make those positive changes that we want to see with their treatment plan. So talking to them about what's going on outside of the office is going to be important for their ability to make positive neuroplastic changes. So when we talk about neuroplasticity of the posture system, why is that so valuable to us as posture professionals, and how can we implement that in practice? So with postural neurology, your patients can achieve neuroplastic changes of the posture system. Now, the control of posture and upright balance requires complex multisensory integration and sensory motor coordination. So neuroplasticity of sensory motor functions then are achieved through brain-based posture rehabilitation. So what we do with postural neurology is we do complete brain-based posture analyses with our patients, and get from that information gathered on the first visit on their baseline neural capacity score, then we create treatment plans around brain-based postural correction. And the point is to drive them to the point of neural fatigue, as I just mentioned, in order to make those neuroplastic changes. So within the research also, it's suggesting that you should utilize active and passive modalities in order to make those neuroplastic changes. So active then is going to be the patient is active. They're actually engaging in the movements associated with their brain-based posture rehabilitation. So doing extension exercises, doing hand-eye coordination exercises, doing VORs, for example. These are all going to be movements of the patient, active movements, active engagement. And then of course, passive is going to be manual therapy or manipulation or adjustments of the posture system, bringing them to the point of having correction structurally in a passive manner. So the combination of active and passive is going to be highly valuable for creating those neuroplastic changes of the posture system. So recognize that incorporating both is going to be very valuable for your patients. Now, what's important to understand too about that active modality, that active engagement in the postural rehabilitation, is that the brain craves complexity. So your brain pays attention to complex movements and complex thoughts and ideas and complex puzzles and problem solving. Your brain really pays attention to those things. Whereas habitual, mindless, repetitive motions, your brain tunes out. So if you think about it, sometimes, if you're driving in a car, for example, if you're taking a walk, maybe you've driven for 30 minutes and you don't even remember driving because it was a mindless activity. You weren't engaged in the process, and so you get to your destination and you think, "Oh, I don't even remember how I got here." You were mindless in that moment. Or if you're taking a walk, your brain isn't thinking, "Okay, heel, mid stance, toe off." It's not thinking about those phases of gait as you're doing the gait patterns. This is a mindless activity. Whereas when you're doing postural rehabilitation and you're very mindful of those complex movements, it's going to really stimulate that cognitive function, which is going to stimulate neuroplasticity. So for example, if you're doing a figure eight pattern, if you're moving a ball in a figure eight pattern around your legs, okay, that's going to be a complex movement because it's multiplanar. So as you're doing that, as your patient's doing that, if they're actually focusing on the pattern of movement and focusing on the muscles that are stimulated and focused on that exercise and activity, then it's more complex and the brain pays attention. So we're going to talk about that a lot today, the importance of being very mindful and paying attention as you're doing exercises to stimulate the neuroplasticity, because once the brain pays attention, then we can create neuroplasticity, versus when we go mindless, then the brain is not paying attention to that exercise or that activity. The more complex it is, the more the brain pays attention. Okay, so we're going to talk a lot about complexity in terms of movements. And also outside of the office, you can also have your patients doing things like crossword puzzles or intellectual pursuits, problem solving activities, engaging in social interactions in which they're doing games or problem solving together is also really important for their brain and for their functional output. So let's talk about specifically how to set up treatment plans, because that's the point of today. I know you guys want to walk away with those implementable goods of how to set up that treatment plan, and I want you guys to have that information. So let's talk about some certain things that are really important for your treatment plans, and then we'll go through an example of it. So the first thing that I want you guys to think of in terms of creating neuroplasticity is specific skill training, or what's called motor acquisition activities, or motor skill acquisition. So specific skill training, motor skill acquisition. Now, when you're doing a motor skill, if you are learning a new skill, think about yourself. Think about an example, maybe the first time you learned how to golf. If you don't know how to play golf like I don't, for example, then there's a lot going on with that golf swing, and it's a very motor-driven activity. So in order to become good at golf, for example, I need to really think about what I'm doing, and I need to create that neuroplasticity of that motor pattern. So when you're learning a new skill, the brain pays attention. So instead of just doing these repetitive motions, like I said, when your mind goes mindless, you want to do motor skill acquisition. So where the patient actually gains a skill from it. Such broad examples are going to be playing piano, learning a golf swing. Whereas maybe in your office, they're just picking up marbles and putting them in a can, in a way with the can moving, for example. So that's going to be a very fine motor skill that's acquired through the activity that they're doing with their brain-based postural rehabilitation, okay? So it doesn't have to always be learning a golf swing or learning how to play the piano. It can be smaller activities, but as long as they're complex and it requires a motor skill, then it's going to be very beneficial. For example, playing hacky sack is another thing that the patient can do in the office or outside of the office that is a new motor skill that's acquired. Okay, and again, complex movements. So I keep talking about complex movements. What I mean with that is that you need to go multiplanar with the movement pattern. So for example, if I do 15 bicep curls just like this, okay, this is not a dynamic, it's a dynamic movement, but it's not a complex movement. So my brain stops paying attention to that movement. Whereas if I do a figure eight across multiple planes of motion, as I'm holding a weight and flexing my bicep, or if I have a really strong contraction, an isometric contraction of my bicep versus doing 20 repetitions without even thinking about it, then the brain's going to pay attention. So multiplanar are considered complex, as well as isometric contractions. So again, if I do a bicep curl, which I'm not saying this is the best form of rehabilitation, but just go with this example here. In terms of this motor contraction, I want to hold it to the point of neural fatigue, because you'll start to see that your brain is really paying attention to the fact that your muscle is fatiguing because you're holding that isometric contraction. That's a good thing, because it demonstrates that the brain is focused on the movement, on the rehabilitation that you're doing. Now, also doing goal-oriented activities. So I talked about, even with motor skill acquisition, it can be as small as, picking up marbles and putting them in a can that's moving. Now, that's goal-oriented. The goal is to move the marble into the can, okay? If you're playing darts, the goal is to hit the bullseye. If you're doing extension exercises, the goal is to keep your back straight, for example, to reverse that postural hyperkyphosis. So having goal-oriented activities, specifically, the patient knows what their goal is with every single activity that they're doing as part of their brain-based postural correction activities, okay? So being goal-focused, also having a goal for each session. So for example, if they're working on isometric contractions of their glutes, the goal is going to be to hold that isometric contraction for 1 minute. Or when they're doing planks for core stability, hold that contraction for a minute. So the patient is they're thinking about and engaged in the goal-oriented movement to then acquire the motor skill required. And then visualization and sensory priming. So visualization is going to be a powerful stimulus and important for the cerebellum. Now, the cerebellum, located just here inferior to the main part of the brain, it's going to be for fine motor output and postural stabilization and adjustments and coordination. So when you're visualizing, the cerebellum and the brain, they're actually picturing how to do the movement. So when you go to actually do the movement, then it's already been created as a stimulus in your brain. So for example, if I'm visualizing how to shoot a basketball and then I actually go to shoot the basketball, then I'm more likely to have better coordination with that movement, because I've already thought about how to do it and I've seen the movement and my brain is paying attention to that activity. And of course I have that goal of getting it in the hoop. So do you see how you can prime the movement by visualizing it first? And then sensory priming is actually drawing attention to that area. So if I'm visualizing how to shoot a basketball into the hoop, and then I actually do sensory priming of this area that I'm going to be shooting with, then I'm bringing attention directly to the body part that's going to be performing the movement. So my brain's thinking about it. I have sensory priming, and then when I go to actually do the activity with my goal-oriented motor skill in mind, then I'm more likely to be successful and create those neuroplastic changes. Okay. And then staircase design. So with your treatment plans, always think about a staircase design. So if you think about a staircase, the stairs are going up. Now, each patient is going to join the brain-based postural correction treatment program at a different stair, meaning that, some of your elderly patients, for example, who are highly compromised, they're going to be at the lower part of the staircase, whereas your athletes are going to be up here in the staircase. But each person has their individual staircase. So the goal for this person down here is to get to the next step on each term that they're doing their rehabilitation. Same thing with the athlete. So maybe they're doing much harder activities that are required to create neuroplasticity, but they still want to make a progression up that staircase every single time they do rehabilitation. Because if not, it's going to be a mindless activity that's just repetitive versus challenging your brain and challenging your body to the point of neural fatigue to then create neuroplasticity. So think about staircase progressions. Going up one step every single time that they do their treatment plans is going to help them create more neuroplasticity. And then performing performance feedback. So performance feedback during rehabilitation is really important for the patient, because they're actually getting feedback if they're doing it correctly. And when they get feedback, the research tells us that they're more inclined and more motivated to continue with their rehabilitation. So if you don't give them feedback, if you're doing 12 weeks, for example, of rehabilitation, and you don't give them feedback regularly, they're going to lose that motivation. So keep them motivated by giving them performance feedback on how well they're doing. And also, if they're not doing well with an exercise, if they have incorrect posture while doing balance, for example, then you want to correct that immediately, because we don't want to create negative neuroplastic patterns, which then leads to more postural distortion patterns. Of course, we want the opposite effect. And then measuring performance and documenting training gains. So if the patient can see physical documentation of their performance gains, then it's going to help them again stay motivated and help them keep reaching their goals, again with that staircase approach. So this is not something that we just want to start them out and then 12 weeks later do a reevaluation. Absolutely not. We want to think about small progressions every single time that they're working on their treatment plan to have those continual gains in order to build neuroplasticity. Okay, so what are some things, we just went over what you want to do in your treatment plan. Now, what are some things that you do not want to do in terms of a treatment plan? What's going to hinder their ability to make neuroplastic changes? The first is mindlessness. So I've already mentioned this. We want the patient really engaged and focused on the activity. We want their brain paying attention. And also pain is going to be inhibitory. So if the patient is in pain and expressing chronic pain patterns, we need to get them out of pain first before we can make those neuroplastic changes in the posture system. So recognize that mindlessness and pain are going to hinder their ability to make positive neuroplastic changes. Also, high repetitions of unilateral movements. Again, keep it complex. The brain craves complexity. Avoid cookie cutter assembly line treatment plans. It just doesn't work. You need to be patient specific and drive them to the point of neural fatigue every single time. And then, of course, avoid flexor dominant exercises. So one of the worst things that you can do if a patient comes in with lack of core stability and they have flexor dominant posture as is, you don't want them in the gym doing a million crunches and sit-ups. You want to help them build core stability by elongating and lengthening and focusing on that kind of contraction versus doing a bunch of more flexor dominant exercises. Okay, so the things that are going to hinder our progress then are mindlessness, pain, high repetitions of unilateral movements, cookie cutter assembly line treatment plans. Just don't even go there. Make it very patient specific, and then flexor dominant exercises as well. Okay. Now, what does the research tell us about how long does it take to create neuroplasticity? So what's really cool in the research, it actually demonstrates that there's two phases. There's a fast learning phase and there's a slower learning phase. So the fast learning phase, what they're showing is that you can actually make neuroplastic changes in one session. So it's not permanent though. So recognize that it's not permanent, but within one session, even just a 15 minutes of motor skill acquisition training, you can make neuroplastic changes. But it's not permanent, so that gives us a reason that the patient needs to come back and continue engaging in their treatment plan. So the fast phase of learning is one session. That's again that staircase. They're going to get a progression every time they do their rehab. But then there's the slower learning phase. So in order to make it more permanent, long-term correction changes, then we need to go for weeks in order to have that improved performance. Okay. So again, fast learning, slow learning phase with neuroplasticity. Fast learning phases says that they're likely to make progression if they do it correctly every single time that they're working on their rehabilitation. And the slower learning phase is going to require weeks of dedicated rehabilitation in order to make long-term neuroplastic changes in the posture system. Okay, so that's super important information for us, because if the patient wonders, once they get out of pain, why should I keep coming back? I know you guys have probably heard this question, or maybe you had a really engaged patient and then they kind of faltered off after you got them out of low back pain, for example. That's because they had that point of neuroplasticity right away and they got out of pain, but what they didn't realize was that they needed to stay with you in order to make the neuroplastic changes in the posture system to reverse the postural distortion patterns that literally brought them to the point of postural collapse in the first place. So once they're out of pain, we want to keep them for that neuroplasticity in order to make long-term changes. All right, so I'm going to share with you guys a PowerPoint so that you can see what I'm referring to when I'm talking about treatment. So now we're going to go through some examples. I wanted to give you guys a visual on these because I think it's a little bit easier when you can see what I'm talking about here. So again, with treatment plans, how much are we doing in terms of frequency and visits and all of that? So again, it's going to be patient specific, but what I want to do is give you my best recommendation under typical standards. Again, you need to do a complete brain-based posture analysis with your patients to make it patient specific, but this is a good understanding of what treatment plans would require. require. Now, overall, you want to do a high frequency of visits initially at the beginning, and think more about low repetitions but high complexity of exercises. So, for example, you don't need to do 20 repetitions, but you do need to have high complexity of your exercises where the brain pays attention. And then also, when you think about doing contractions, so if you're doing strength training, for example, for the motor cortex, then you want to think about the patient holding the contraction longer versus doing a higher amount of repetitions. So low repetition, high complexity, low repetition, hold that contraction for a minimum 10 to 30 seconds. And then also be patient focused. We want the patient to be focused, we want them motivated, and we want them mindful during their rehabilitation. They're tuned in while they're doing this. If they're tuned out, to be quite honest, it doesn't help very much. And then, of course, having phases with your exercise progressions. So it's not adequate to give patients one set of exercises and then say, okay, we'll do a reexamination in 12 weeks without changing anything. You want it to be that staircase progression to continually get more hard, to continually get harder and more progressive. So for example, we'll go through some specific examples, but if you have the patient doing figure eights, for example, maybe they just start by doing figure eights without a weight, and then they add a weight to that, and then they add more resistance, and then they do it on whole body vibration. Do you see how those are different progressions that can keep the patient engaged throughout their exercise progressions? Okay, so here's a sample treatment plan in terms of in-office rehabilitation, manual therapy such as manipulation, massage, acupuncture, osteopathy, and then of course at-home rehabilitation. So we generally do a 12-week brain-based postural correction plan. Now this is again going to vary among certain patients, but overall the average is going to be 12 weeks. So phase 1 is going to be the first 2 weeks. Now within phase 1, we're talking about with in-office rehabilitation 4 to 5 times per week. So the patient is coming in 4 to 5 times per week, and they're going straight into the rehabilitation room to really work hard on their in-office rehabilitation. Now the reason they come into the office is because we have some of the gadgets. We have the whole body vibration, we have all the different things for them to utilize within the office that they likely don't have at home. And then manual therapy. So they're going to get 3 to 5 corrections per week, patient dependent. Now, if they've already gone through a structural phase of care in our office, then they're likely going to get just 1 to 2 adjustments per week or manipulation of the spine, 1 to 2 per week. But if they have not gone through that structural phase, then it's going to be 3 to 5 corrections per week at the beginning in phase 1, which lasts 2 weeks. And then at-home rehabilitation, they're going to do that 5 times per day. So again, you don't want to make the treatment plans when you're giving the patient at-home rehabilitation. You don't want to do long treatment plans, you don't want to do treatment plans where it requires them spending a long amount of time each day. But what you want to do is have them do it 5 times per day. So if you can get them to do very specific exercises that only take them 10 to 15 minutes, but they do that 5 times per day versus spending 1 hour doing their rehabilitation, you want them to do it 5 times per day. Okay? And then phase 2 is going to be 6 weeks. So in-office rehabilitation is going to be twice per week, 2 corrections per week, and then 5 times per day with that at-home rehabilitation. And then recognize that they're going to change their exercises from phase 1 to phase 2. And then phase 3 is for 1 month, and that's going to be once per week for in-office rehabilitation, 1 correction per week, and 5 times per day still for the at-home rehabilitation. And again, with each phase, there's going to be different exercises that are based upon more complexity and more difficulty to keep the patient progressing forward. So I wanted to go through some examples specifically of different parts of the brain that we would be targeting within postural neurology and give you guys some progressions that you could utilize throughout the 3 phases of care. So if we talk first about the motor cortex is located within the frontal lobe, and the motor cortex is so important for motor output. In fact, it controls all motor output. So if your patient has, for example, if you do a brain-based posture analysis and you see that they have decreased, lack of arm swing on gait, they go weak when doing muscle tests, these are indications that we want to stimulate the motor cortex. So you can see in the picture here, one of a good exercise that you can do is for glute strength. So an isometric clamshell exercise. So the first image here is without resistance. So I would start here first, and the patient would build up the amount of time that they can do. So you want to go for a minimum of 30 seconds. A minute's going to be better. So in phase 1, they're just working on really contracting those glutes. And then in phase 2, we're going to do the same exercise, but we're going to add that resistance band, which you can see in the second photo. So again, they're going to go from 30 seconds to a minute being the ultimate goal. And they're really going to hold that contraction. So it's not going to be just a light exercise. It's going to be a really intense contraction of that musculature. And then the third progression for phase 3 is going to be the isometric clamshell exercise, just as pictured, but with E stimulation. So what you're going to do is you're going to put the E stim unit right on that muscle that's being contracted, the glutes, and you're going to fire the glute with the E stim while doing the muscle contraction. So that would be the third progression. So you guys can see how we took the same exercise and we made it more difficult as progressions throughout their treatment plan to really stimulate that motor cortex in order to make neuroplastic changes. The thing that we would not want to do is have them do the exact same clamshell exercise for 12 weeks. We want to mix it up and make it more difficult for the patient. Okay, and then if we're talking about the sensory cortex. So the sensory cortex, so the sensory homunculus, is located within the parietal lobe. Now, the sensory cortex perceives and understands and interprets all of the stimulus that we receive from our environment, from our body. So some examples to stimulate the sensory cortex are going to be functional tape application, skin stimulation, such as massage, or vibration, all of which are going to be sensory cortex stimuli. So in phase 1, for example, you could put functional tape on the patient so that they have that stimulation on their skin. So that stimulation is going to be a constant stimulation while doing the rest of their brain-based postural correction activities. And then you could do skin stimulation. So I talked to you guys about visualization and sensory priming. So this would be a sensory priming. Skin stimulation, you can sensory prime an area that you're working to strengthen, that you're working to improve the sensory perception of. And then the third progression would be vibration. So you can do targeted vibration to a certain side of the body that's then going to stimulate the contralateral sensory cortex. That's really great sensory priming before or while doing other exercises as part of the patient's postural correction treatment plan. And then next is the vestibular system. So for vestibular system, I have it again broken down into 3 phases. So in the first phase, you would have the patient doing one leg balance. You can see that in the first photo. So this is just going to be on a regular, on the ground with the eyes open. And then in the second phase, one leg balance with eyes closed, for example. And then one leg balance on an unstable surface. So we just took the same exercise and we made it progressively more difficult that the patient is going to do throughout their treatment plan. Now, of course, with one leg balance, it's really important that they're doing this with proper posture. So it's going to be considered insignificant, or it's going to hinder their ability to make changes if they have poor postural patterns during their balance exercises. So check the patient's balance, give them that performance feedback that we talked about before to make sure that they have proper postural design while doing one leg balance. The goal is going to be 30 seconds with this, so the patient should be very focused on that goal in order to get their outcomes that they're looking for in terms of neuroplasticity of the vestibular system. And then last, we're going to talk about the cerebellum. So with the cerebellum, again, the cerebellum refines motor output. So something that you could do in phase 1 would be figure eights at the upper and the lower body in Romberg stance. So for example, if I'm standing in Rombergs, then I'm already stimulating the midline cerebellum. Now, if I do figure eights of my upper body where I'm utilizing my whole arm, that's going to be the intermediate cerebellum. And if I just do my wrist, that's going to be the lateral cerebellum. So start them off by doing that. And then the patient can move into a sharpened Romberg stance. So sharpened Rombergs, instead of Rombergs with the 2 feet together, you're going to have one foot right in front of the other. It's going to be more difficult to balance in this position. So then doing figure eights in the sharpened Romberg stance makes it that much more difficult for the patient to then build neuroplasticity. And then a third progression could be finger, nose, finger exercise. So for example, the patient, maybe they have a screen, or maybe you have certain things out on the table. They're going to touch their nose, touch a target, touch their nose, touch a target, or touch their nose, touch your finger if you're doing it actively with the patient. They touch their nose, they touch your finger, and you can move your finger in space to make it that much more difficult. So these very precise motor movements are going to be really great for a stimuli of the cerebellum. Okay. So we just went through some examples of things that you guys can do with your patients in your office to stimulate different parts of the brain. So again, we went through the motor cortex, the sensory cortex, the vestibular system, and the cerebellum. So if the patient was weak in those areas, then you would want to build neuroplasticity by doing exercises to target those areas of the brain and doing so in that staircase fashion, keeping the patient very mindful. So let's go through a case study or a patient example. Now, I chose this patient example because I know you guys are seeing a lot of low back pain patients. So the patient comes in, they have chronic low back pain. This is the patient that comes in, they're like, "Doc, I've been in pain for the last 10 years. Now, the patient also has weak core activation and they have flexor dominant posture. So this is probably representative of 70% of the patients in your office. Now, chronic low back pain, weak core activation, flexor dominant posture. This is so common. So then we did a brain-based posture analysis. The patient had a neural capacity score of 41 out of 100. They had right midline and lateral cerebellar deficits. Cranial nerve 7 and 12 on the left side were deficient. The Fukuda test for the vestibular function showed lateralization to the left with left horizontal canal dysfunction of the VOR, so left vestibular. Right divergent eye, so right vestibular system was right visual system dysfunctional. And then the posture analysis showed forward head posture, left head tilt, postural hyperkyphosis, and left toe out foot flare. So that's what the patient presented with. So before we talk about what to do, let's talk about what we don't want to do with this patient, because as important as it is to know what to do, it's also important to know what not to do with the patient. So first of all, we're showing indication of cerebellar dysfunction, meaning that we don't want to adjust the patient bilaterally. We want, with our manipulation, to be very specific to the site of cerebellar dysfunction. The second thing is don't have the patient do the flexor exercises with their rehabilitation. So to build core strength, we know they have a weak core. We don't want them doing sit-ups in the gym. We want them doing exercises like planks and extension exercises. And then, of course, we want to avoid high repetitions of traditional strength training. So we don't want them just in the gym doing a million repetitions on the bench press, for example. We want them doing very complex movements that are going to stimulate neuroplasticity. That's what's really going to get them better. So what to do on this is a sample treatment plan. So cervical manipulation is going to be on the left side. So we had left head tilt, which is leaning towards the site of vestibular dysfunction. So cervical manipulation would be on the left side. We also saw that there was cerebellar dysfunction on the right side. So we're going to do thoracic and lumbar manipulation and extremity manipulation on the right side to stimulate the right cerebellum. That's an ipsilateral relationship. And then the PMR wrap. So the pontomedullary reticular formation, you guys, is located in the brainstem between the pons and the medulla, and it's in charge of inhibiting flexion. And it's also the home of the cranial nerve nuclei, cranial nerves 5 through 12. So we saw that there was decreased function of cranial nerve 7 and cranial nerve 12. So because the PMRF inhibits flexion, what we want to do to stimulate that is to do extension exercises. In addition to that, because we saw deficits of cranial nerve 7 and cranial nerve 12, we want to actively engage these cranial nerves while doing extension exercises. So for example, for the facial nerve and for the hypoglossal nerve, then you want to be doing facial stimulation, and then you want to be working with the tongue, for example, as well, to stimulate those cranial nerves while doing extension exercises. And then for the vestibular system, doing the balance progression. Now, specifically on the left side, because they had left vestibular dysfunction. You can do it on both because the patient needs to develop balance on both sides. But if you want to do it more specifically, for example, adding vibration while the patient's standing on their left leg, that would be a good progression. Cerebellum, motor skill acquisition on the right side. So we saw that there was a right cerebellar deficit. So when we're doing motor skill acquisition, you can see in this picture here, I'm throwing a ball against the wall trying to hit a target. So that's going to be, I'm going to do that with my right hand to stimulate that right cerebellum, and it's a motor skill that's acquired. So hitting a small target on the wall is difficult to do. So I want to do that with the goal in mind of hitting that target. And then for the visual system, we're going to work on convergence exercises because I have a divergent eye on the right side. So working on small eye circles to improve convergence. And for core training, the patient would be doing planks, side planks, and sitting on a posture cushion. So while sitting on a posture cushion throughout the day, it's really beneficial to the patient for multiple reasons, but one of the reasons being activation of their core while at work, for example, while sitting at their desk. So that's going to be a very valuable treatment plan for that patient. Now, don't forget, so with this sample treatment plan, the patient needs to be focused and mindful. We want lower repetitions with high concentration, high complexity, and high contraction levels. We also want that staircase progression of the exercises. And then the patients, they want to get to the point of neural fatigue on each visit or each time they do their rehabilitation. Also, keep track of the patient's progress and provide performance feedback throughout the patient's treatment plan. Challenge the patient to the point of neural fatigue and encourage them to sleep well, nourish their bodies, and stress reduction. Because as we talked about at the beginning, those are factors that lead to the patient to the point of negative neuroplasticity, which of course we want to avoid. So have that conversation with them so they get the most maximal benefit from your treatment plan. Let's see. Now I'm back with you guys. So we just went through some examples of what we would do specifically with our patients in our office and some sample treatment plans. Again, I do want to iterate, you guys need to do a full examination before coming up with the treatment plan, but this is a really good start that you guys can compare to and think about how you can implement it with your patients. So in addition to this, guys, I just wanted to kind of give you a call to action here to really think about neuroplasticity. If nothing else, this week in your office, really think about how you're currently seeing your patients, the treatment plans that you're putting them on, and ask yourself, is it creating neuroplasticity? Because if it's not, then we don't want to waste the patient's time. We certainly don't want to waste your time. So think about your current treatment plans and how you can take your patient to the next level in terms of getting results, staying results focused, keeping it very patient specific, and helping them build neuroplasticity of their posture system. Because that's going to be the difference from the patient who got out of pain in a couple of visits versus the patient who stayed with you and got long-term postural correction changes. So think about that in your office. So step one is just to think about your current treatment plans. Do they stimulate neuroplasticity or not? And then the second is to implement, to take action. So think about how you can start implementing that staircase progression, how you can create a more mindful environment within your practice, and maybe you need to start increasing the amount of times that the patient is doing their activities per day outside of your office as well, okay? So that's a postural neurology approach, again, to create neuroplastic changes in the posture system. That's what we're all about with postural neurology. We're all about results and understanding what the patient actually presents with. Being able to look at the patient, understand what they present with, understanding how to set up treatment plans that make sense for that patient specifically, how to get results and get neuroplastic changes. So if you guys are not already a part of our Facebook group, I invite you to join us in the Postural Neurology Facebook group. We're constantly doing education in that group. If you guys have any questions, like, I just implemented this with this patient and I'm seeing this result, how can I improve? Just post it in the group. We're more than happy to give you guys feedback to keep you getting those really great results with your patients in the office. So again, the Facebook group is just called Postural Neurology. We want you guys to join us in that group so that you guys can stay up to date with what's going on in the world of postural neurology. All right, so at this point, I wanted to open it up for questions. I can see you guys have some comments along the side here. Angela, Wisconsin joined us. Jeffrey says, got research to share, document, and validate feedback when dealing with insurance companies. Very nice. Yeah, it's important to understand the research, making sure that it's an evidence-based approach. One thing I didn't mention, guys, I just put together an evidence-based guide on neuroplasticity. So I'm going to post that in the Facebook group at the end of this week or maybe the beginning of next week. But just be watching the postural neurology group because I went through a ton of research studies. I give you guys all the references. I actually go through and break down the studies so you guys can have that evidence-based information just right there. We're going to send it to you via email. Okay, so we'll post that in the group and then you guys can get it to your inbox. Nicholas, good point. Excellent. Okay, Jeffrey says, great presentation. Crucial to give patients feedback to keep them engaged, excited, and compliant. Yes, absolutely. So again, you don't want to just get the patient excited at the beginning and then just kind of ignore them throughout their treatment plan. You got to give them that performance feedback to keep them motivated, keep them on point. Angela says, this is really helpful to see and hear. This is a wonderful way to structure change with new patients and apply with current patients as they make that transition to the neural approach. Angela, thank you for mentioning that. That's absolutely true. It's really important to actually have the conversation about neuroplasticity with your patients because when they understand the amount of change that they can get when they're actually engaged in the process, it's really extraordinary. And you can see that light bulb go off for the patient. So this again takes you from that patient who comes in for 3 visits, gets out of pain, and then doesn't come back. We want to get them out of pain. Absolutely. That's our first goal, because that's going to hinder neuroplasticity if they're still in pain. So get them out of pain first, and then we got to keep them in the office working hard on those treatment plans in order to create neuroplasticity of the posture system. Because again, there's 2 phases of learning. There's the slow phase, the first phase, and the fast phase and the slow phase. So with fast phase, they make the stair-step progressions on each visit, but with that slower phase, they need that time of dedicated posture rehabilitation in order to make those long-term changes. All right. Awesome. Thanks for the research. You're welcome, Jeffrey. So you guys just check the Facebook group, Postural Neurology. We're going to post in there. I'm going to give you guys an evidence-based research guide regarding neuroplasticity. It's going to go through a lot of the stuff I went through today, but what's cool about that is I actually give you all the research studies as references as well, so you guys can have that information. I know you guys like research. Kevin says, great talk. I'll go from structural CPE to neuro. Inputting this will create the interface. Awesome. Yep. So you're already a CPE. And be sure to reach out to us too. We can talk to you about how to bridge between that structural and dynamic phase into the brain-based phase. So that's going to keep your patients throughout multiple different phases of care, which is really awesome. That's when you see major changes happening in the posture system. I mean, absolute transformations with patients. Again, it's all about results. And I want to thank you guys again for joining us. Kevin says plan on it. Awesome. And Kevin, we'll see you in the Facebook group as well. So again, just keep in touch with us, guys. We want to hear what you're doing, how you're implementing. If you have any questions, just shout out, let us know. We'll do webinars, we'll do Facebook Lives about the questions that you have, because if you have that question, somebody else does too. And we want to make sure you guys have the tools that you need, and the tools and the resources to get those great changes in practice. So guys, make it a great day. Remember, it's posture by design, not by circumstance. Give us a shout out on Facebook. Let your friends know that you're extending your education with the American Posture Institute. Be sure to join the Facebook group Postural Neurology, and we'll see you in the Facebook group. Bye.